Richard Bogan, and on behalf of CME Outfitters, I would like to welcome and thank you for joining us for episode 3 of this 4-part CMEO snack series detailing highlights from the SLEEP 2021 meeting. Today's episode is titled Real-World Strategies for the Management of Narcolepsy, highlights from the 2021 SLEEP meeting on dosing and titration. This CMEO snack series is supported by an educational grant from Jazz Pharmaceuticals Incorporated and is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. Again, I'm Richard Bogan, president of Bogan Sleep Consultants, LLC, and I'm also an associate clinical professor at the University of South Carolina School of Medicine in Columbia, South Carolina, and associate clinical professor at the Medical University of South Carolina in Charleston, South Carolina. I'm especially pleased to be joined today by Dr. Michael Thorpe. He's professor of neurology at the Albert Einstein College of Medicine, as well as director of the Sleep-Wake Disorders Center's Department of Neurology at Montefiore Medical Center in Bronx, New York. He is also president at the New York State Society of Sleep Medicine and past president of the sleep section of the Academy of Neurology. Welcome, Michael.
Good. Thank you, Rick. It's a pleasure to be here with you today.
Yeah, this is great. We're going to have a great discussion, again, based on some of the science from the SLEEP 2021 meeting. And to frame today's episode, let's start by reviewing our learning objective, which is to apply updates from recent clinical trials on optimal strategies to dose and titrate pharmacotherapies for the management of narcolepsy. So, Michael, before initiating treatment with any patient, and our narcolepsy patients are profoundly sleepy, there are core concepts that every clinician should first consider to optimize treatment outcomes. Can you share some of those core concepts with our audience?
Yes, Rick. Well, when it comes to narcolepsy, we have quite a variety of medications that have different mechanisms of action. So it's absolutely essential to be aware of those mechanisms of actions and also what the different dosing regimens are and the reason for using the different medications that we have for narcolepsy. Now, you need to have appropriate dosing to therapeutic objectives so that if a dose is too low, then patients are not going to be treated efficaciously and they're going to have a tendency to discontinue their medication. Or if the dose is too high, obviously, then you're going to get side effects that, again, may lead to discontinuation. So you need to titrate to effect for most patients because narcolepsy is a difficult condition to treat because of the severity of sleepiness in most patients. And it's very difficult to get rid of that sleepiness completely. So we need to try to maximize the dosing without getting adverse effects. And then for many patients, because there are such a large number of options available to us, we have to consider switching from one medication to another depending upon the clinical circumstances.
Yeah, thank you. You've written several publications that explore some of the mechanisms of actions and what we're doing in narcolepsy patients when we're sort of pinging these neurons to try to excite them and improve speed of processing and improve the sleepiness and fatigue in these individuals. And they're, as you said, they're hard to treat, and we're constantly sort of searching, pinging the brain to see what works. And many of these patients do have polypharmacy, and we're changing medicines around and switching them around. So with those things in mind, Michael, talk to us about the current treatments for narcolepsy and how they differ in terms of their mechanism of action.
Right. So everybody's probably familiar with the traditional stimulants, you know, the methylphenidate, the amphetamines. I mean, they've been around forever. And they are sympathomimetic medications. They work through dopamine, norepinephrine, serotonin mechanisms. Then after the traditional stimulants, we had the modafinils, regular modafinil and armodafinil, a longer acting form of it. These tend to be dopamine transporter inhibitors, so again, they work through a dopaminergic type of mechanism. Then we have oxybate, and there are several different forms of oxybate available to us at the present time. These work through a GABA B receptor mechanism. We have a regular sodium oxybate, and then there's a new lower sodium formulation available. Then we have solriamfetol, relatively new medication. It's a dual dopamine norepinephrine reuptake inhibitor, so it works through a dopaminergic and norepinephrine mechanism. And then finally we have pitolisant. And pitolisant is a rather unique medication because it works through a histaminergic mechanism. What it does is it affects the H3 receptor. And so it's an H3 receptor antagonist and an inverse agonist, and increases histamine in the brain, thereby improving alertness, and also is efficacious for cataplexy as well.
Yeah, you raised some good points, and as you mentioned earlier, it's important for us to know about dosing and the pharmacokinetics and the pharmacodynamics of these drugs, and because oftentimes we may be using them in combination, and they certainly have different mechanisms of action. And when you begin to get to real world activity, your study actually kind of helps us. So planning and management and personalizing dosing and titration strategies for our patients. So you were involved in this key study on this topic presented at Sleep 2021 meeting in your poster entitled Solriamfetol Titration and Administration Start, Dosing and Titration Strategies in Patients with Narcolepsy, Starting Solriamfetol. Can you tell us about the study design?
Yes, Rick. This is an interesting study. It's a retrospective patient chart review. There were 23 physicians who prescribed medications to patients, in particular prescribed solriamfetol. And they selected charts from 70 patients with narcolepsy. Most of these patients were type 2 narcoleptics, but a third of them were type 1. But they were patients who had pretty severe narcolepsy. They had moderate to severe degree of narcolepsy. So what they looked at is how physicians prescribed solriamfetol in these patients. And there were really three ways that they prescribed it. There were de novo patients, that is, patients not taking any medications for excessive sleepiness, and so they just started off with solriamfetol. Then there are those patients who were already taking medications, some of the ones that I mentioned earlier, and then they switched them over to solriamfetol. So they changed them. They were transitioned from one medication to the solriamfetol. And then finally, there were the patients who were taking medications for their narcolepsy, and they used solriamfetol as an add-on to the medication that they were already taking.
Yeah, this is what we do in the clinic. We're trying to figure out how to transition these patients or start therapy or, as you say, polypharmacy and add-on. What were your findings?
Okay, well, first of all, let's start with the dose and the number of dose adjustments that they needed. Solriamfetol comes in two dose forms, a 75 milligram and 150 milligram form. Now, in narcolepsy, the 75 and the 150 is generally the recommended dosing for patients who have sleep apnea, because solriamfetol is actually FDA approved for sleep apnea as well. They are recommended to start at 37.5 milligrams, slightly lower dose. However, in this study in these patients with narcolepsy, most of the physicians generally started with a 75 milligram dose and then increased that, and their final dose was the 150 milligrams. Some of the physicians started with the lower dose, the 37.5, and then made one or two dose adjustments in order to get to that 150 milligrams. Some clinicians actually started with a higher dose, the 150 milligram dose. I assume these are patients that were been on high doses of medications previously, and so they already just started them at that higher dose. Now, in most cases, what they found was that the patients who were de novo, they either didn't have any adjustment, they went straight to the dose, or in most cases there was one, so they dose adjustment. So for those patients who had not been on any medications, generally the physician started at 75 milligrams and then titrated up to the 150. And that also happened in those patients that were crossed over from one medication to solriamfetol. So those in the transition from one to the other, generally they made one dose adjustment. So again, starting at the lower dose. Now, with the when it was added on, again, some patients actually just gave them the higher dose and didn't make any further adjustments. But a small number of them did tend to make a dose adjustment, going from 75 to 70 to the 150. So overall, most of the physicians tended to titrate the dose. So they made at least one dose adjustment.
Yeah, based on the pharmacokinetics of this particular drug, you'll get a signal in about an hour because the Cmax or the Tmax is probably 2.5 hours and the half-life 6 hours. So you can see a signal pretty quickly in these individuals. And again, the duration is about 9 hours. So the dose adjustment can be done fairly quickly. I know in the trials we made dose adjustments every 3 days. So that's interesting. What were some of the patient factors you think that influenced physicians when they were titrating patients onto solriamfetol?
There are a number of reasons why physicians would put a patient on to solriamfetol and change them over from another medication. I mean, obviously, sleepiness is the main reason why we're going to be giving solriamfetol because it's efficacious for that. So in most cases where patients were not very effectively treated in terms of their excessive sleepiness, that's the reason why the physicians would give it. But sometimes it was because of side effects that the patients may have had with the other medications or comorbidities that the patients had where the current medications they were taking were interacting with the patient, and so they needed to change them from medication to solriamfetol. And then there would have been some patients who may have been on oral contraceptives, for example. We know a number of the medications for narcolepsy will interfere with oral contraceptives, but that doesn't happen with solriamfetol. So they may have been changing them over from those medications to solriamfetol for that reason.
Yeah, that's a good point. I mean, solriamfetol is excreted through the kidneys and not metabolically changed and doesn't inhibit or activate the CYP enzyme, so we don't see the interaction with oral contraceptives, and so that might affect our decision making. And lack of efficacy is another. I mean, we might try something and it doesn't work, and we're obviously going to move on. And as you said earlier, our patients are really tough to treat. So, and we're constantly looking for what might work.
Right.
So, yeah. What did you learn about the previous medications that patients transitioning to solriamfetol were taking?
Well, the patients who are already on medications and then were changing over to solriamfetol, they comprise three groups. The majority of them were patients that were on weight-promoting agents. I mean, these are the modafinils. So either regular modafinil or armodafinil. Second biggest group were those that were on stimulants, and they wanted to change them from the stimulants to solriamfetol. There was actually one patient who was on sodium oxybate who they were putting on to solriamfetol. One can only assume that there was some adverse effect with the sodium oxybate that caused them to want to transition them from sodium oxybate to the solriamfetol. Mm-hmm. In most cases, particularly with the weight-promoting agents and the stimulants, they tended to stop the medications pretty abruptly. With the stimulants, there was more often some tapering down of the dosage and changing over either before starting solriamfetol or after they started solriamfetol. The sodium oxybate case, they tended to taper down and discontinued it once they started the solriamfetol. So there were different strategies depending upon the medications that were being changed over from.
Yeah, I see. But, as far as the sodium oxybate is concerned, as you well know, 80% of people on sodium oxybate, at least that statistic I use, is 80% are on some wakefulness promoting medication or stimulants along with it. So you can use them together, but presumptively, as you say, in that one patient, there might have been some issue going on. but it doesn't preclude using solriamfetol along with the sodium oxybate. So what did you observe about dose adjustments in patients adding solriamfetol to the other excessive daytime sleepiness medications?
Right. So we had patients that were on those three different classes of medications, so wake-promoting agents, stimulants, and sodium oxybate. So before they started the solriamfetol, with the wake-promoting agents, some of the physicians did make some dose adjustments. I think it would be reasonable. They must have felt that there was going to be some interaction there, so they tended to make one or two dose adjustments to the wake-promoting agents before they started the solriamfetol. With the stimulants and the sodium oxybate, they didn't make any prior adjustments, so that they started the solriamfetol while the patients were still taking their prior dose of stimulant or sodium oxybate. When it came to after they had given or started the solriamfetol, then they started to make adjustments with the stimulant dose. So once they'd put them onto the solriamfetol, they began to phase out and reduce the dose of the stimulants, whereas with the wake-promoting agents and the sodium oxybate, they generally kept those pretty stable throughout the time that they were adjusting and the solriamfetol.
Right. Yeah, I think this is valuable information because in the clinical trials, as you well know, our experience is with the drug because we exclude most other medications. So real world strategies are evolving here. So thank you, Michael, for discussing these results with us. It's always insightful to examine real world practices as it gives us an opportunity to reflect on what we do with our own patients. And would you like to add any concluding remarks about what you've learned about dosing and titration strategies with solriamfetol, and maybe perhaps even share your own experience?
Sure. So let me summarize this, what we found in this study. So most physicians generally started their patients with 75 milligrams of solriamfetol and then titrated up to 150 milligrams. They actually did that titration over a median of about 14 days. So it took a little while before they got up to the full dose. When patients were transitioning from one drug to solriamfetol, they were previously taking wake-promoting agents, and they tended to discontinue those fairly abruptly. So most physicians, if you've got a patient on a wake-promoting agent, you can start off pretty well straight away, stop the wake-promoting agent, start with 75 of solriamfetol, and then gradually increase up to the 150 milligrams of solriamfetol. If they were on stimulants, the physicians preferred to generally taper those stimulants and not just stop them abruptly. And that makes a lot of sense for people that may have been on amphetamines, for example. You don't want to just suddenly abruptly sort of stop them, but taper them off before you add the solriamfetol. If you're going to be adding in solriamfetol to other medications that a patient's already taken, then typically you would adjust those wake-promoting agents a little bit as you add, so you don't get too much stimulation effect from both the wake-promoting agent and the solriamfetol. And also, again, once you're adding in, if you're going to keep them on both, you might adjust the stimulants to a slightly lower dose. I mean, ideally, you would want to reduce those stimulants. I think preferably if solriamfetol is very effective for treating the sleepiness, then ideally, if you can get them off the traditional stimulants, I think that's better because the newer agents are far more specific for narcolepsy and for the excessive daytime sleepiness. So it's better to have them on the newer agents if you can. Generally, if patient was on sodium oxybate, then there weren't any adjustments done then to the sodium oxybate, and that's because sodium oxybate is a very effective agent for both sleepiness and cataplexy. And so in most cases when physicians were adding solriamfetol, they really wanted to get that extra benefit in terms of the effect on daytime sleepiness. So no need to adjust the dose. If a patient was on a stable dose of sodium oxybate or low sodium oxybate even, the best thing is just to add in the solriamfetol. In most cases, the strategies that we mentioned here, after the physicians had done them, they felt pretty comfortable with those strategies. They thought that they were effective in helping get the patient onto solriamfetol, and they would, in most cases, they've said that they would recommend the strategy that they use. So I think we've discussed, several different strategies here for changing over and adding in solriamfetol. And this new agent, solriamfetol, has been shown to be an effective agent for sleepiness. And so many physicians are going to want to change over their patients, either add in solriamfetol or change them from their prior medications to solriamfetol. And that's certainly what I'm doing in my clinical practice, because I find that solriamfetol is a medication that has a relatively low adverse effect profile and is an efficacious agent for excessive daytime sleepiness.
Yeah, that's very valuable. And I think the other thing that we learned from the research trial was tolerance, rebound, and withdrawal. I mean, there was no evidence of tolerance, at least in the trial. And so it is a novel, relatively new molecule, been out a couple of years. So this is extremely helpful. So we better wrap it up with our SMART goals. That is, actions that we hope you can use in your practice. And they are: take a patient-centric approach to the management of narcolepsy, dose appropriately to achieve therapeutic goals and discuss dosing regimens with your patients, and titrate to maximal efficacy when minimizing side effects on an individual basis. So please visit the Sleep Disorders Hub at cmeoutfitters.com for a wide variety of additional activities and resources on sleep disorders for both healthcare providers and patients. This has been episode 3 of the 4-part CMEO SNAC series, detailing key highlights from the Sleep 2021 meeting. We hope that you will take advantage of the additional short, focused activity in this series. We will discuss key studies highlighting the safety and efficacy of lower sodium oxybate in the management of idiopathic hypersomnia, as well as the significance of cardiovascular comorbidities associated with narcolepsy. To collect your credit for today's activity, you can click on the link to complete the evaluation. You will be able to print your certificate from the platform. Michael, again, I would personally like to thank you for sharing this data with us today. It really gives us a glimpse into real-world practice strategies that can inform what we do in our own practices.
Thank you, Rick. It's been a pleasure to be able to discuss the study with you. And as you say, this is really practical advice that many physicians treating patients with narcolepsy can get some real meaningful information from.
And of course, I would like to thank you, our audience, for participating and providing the best care for your patients.